John has been in has run a clinical trial comparing milrinone and the serotype. So I'm very interested in his comments on this excellent new work. I do want to mention just a couple of things about the Congenital Heart Academy. I wear a couple of hats. One is of the Congenital Heart Academy. One is in the Pediatric Cardiac Intensive Care Society. And I'm also the co-chair of the 8th World Congress of Pediatric Cardiology and Cardiac Surgery. We're happy to announce the partnership with the Congenital Heart Academy as our formal educational partner. We are in the process of working out the details of how some of the sessions from the World Congress will be provided after the fact on the Congenital Heart Academy website and live with the speakers. We're very excited about leaving some of that as enduring materials. And I would ask people to save the date for the live Congress here in Washington. It is August 27th through September 1st of 2023. So 18 months and 4 days from now. Not that I'm counting exactly, but it's 18 months and 4 days from now. And then my other good friend just joined on, PP Roelveld. Hi, Peter. Usually Peter has 100 guitars in the back of his studio there.
Now it's a hospital. Thanks for having me.
I know you're in your studio, Peter. Thank you for coming. I think at this point we probably should just start. I don't know if Santiago, Kashut, Sharmil has anyone talked about the order of things yet? I'm sorry that I logged on late.
No, we haven't. We haven't yet talked about the order of things. The problem is that our speaker is not yet online. He's online yet, but he's not on the panelist list for some reason. I don't know why. Okay.
Is there a way to send him a panelist link?
I'm working on this.
Okay. Well, why don't we just have the other three people haven't heard from just say a few words about sort of where they are and how they got involved in this. And Santiago, why don't you start?
Everyone, I can introduce myself. So I'm an anesthesiologist. I'm from the scientific committee of the Spanish Society of Anesthesia and also Intensive Care Society of Andalusia. And I used to work with levosimendan from years ago. Also, I participated in some research, like relevant study in Spain with Marc Vives from Hospital Trueta in Girona of Spain. And this is my 2 points from my introduce. I'm doing more education and research on levosimendan from the SEDA and Samiuk Society Scientific.
Excellent, perfect panelist. That's great. Kaushik.
Hi everyone, I'm Dr. Kaushik Jyotinath. I'm from GKNM Hospital in Coimbatore, and we've been doing a lot of research work with levosimendan over the last 4 years. That's about it.
Thank you. And
basically an anesthetist, a pediatric cardiac anesthetist, and double up as an intensivist as well.
Excellent. So some hands-on users taking care of critically ill patients. Perfect. Sharmil?
Yes. Then we have Dr. Reena Joshi. Dr. Reena Joshi is here. Ma'am?
Yeah. Hello. Yeah. Good evening, everyone. And I think for most of you, it's a good morning. Greetings from India. I'm Dr. Reena Joshi, and I'm a pediatric cardiac intensive anesthesiologist. And thanks for inviting us to this esteemed journal club. And today we are happy to present our own paper here. And Dr. Abhim Rattan, who is a cardiothoracic resident, final year, is going to speak on this paper. Thank you, everyone.
All right. You want to try? Let's share your screen if that's possible. And to remind people, I also want to remind people that please ask your questions of the speaker and the panelist in the Q&A and not in the chat. That will allow us to save this to the presentation. And I'd remind all of the panelists, if you have the opportunity to look through the Q&A and answer the questions as they are coming through, that would be very much appreciated.
Yeah, so Dr. Vanosky, I will have a lot of questions from you.
It's perfect study. I have no questions whatsoever.
Thank you so much. Thank you.
So I should start sharing the screen?
That would be perfect. Yes. Thank you.
Yeah, 1 second.
I know as you're pulling up the slides, both John and I have busy intensive care units, which may ask us to step away temporarily. So please mind that as we move forward. And if I have to go away, Sasha and Peter, you can certainly take over as hosts. Thank you.
Okay, should I start?
Yes, please.
Yes, please.
Okay. So good evening, and thank you for inviting me today. I'm honored to be presenting this paper in the midst of such eminent doctors. I'll be discussing the study on the use of levosimendan as a primary inotrope in pediatric cardiac surgical patients, published in 2016 in the Annals of Pediatric Cardiology, with Dr. Reena K. Joshi as a primary author from the Department of Pediatric Cardiac Sciences. As a disclaimer, I would like to point out that I'm a resident in the same unit. This study has no conflict of interest or financial support. So coming to the question of why we picked this particular topic. So there are numerous studies which have documented the fall in cardiac output after congenital heart surgery and concluded that nearly 25% of these cases present with clinically apparent LCOS, low cardiac output syndrome. Now, there are various protocols present all over the world which use combinations of inotropes to combat the same. These combinations are usually managed by conventional inotropes to improve LCOS, but may have unwilling side effects such as chronotropy or increase in systemic vascular resistance, which may further increase the afterload to the heart. Now, levosimendan, the so-called newer kid on the block, acts through a different mechanism by increasing myocardial calcium sensitivity and thus improving inotropic effect of the myocardium. In addition to which, it also exerts a cardioprotective effect by opening the mitochondrial potassium channel of cardiomyocytes. So just giving a brief introduction of levosimendan, as it improves cardiac output without myocardial oxygen environments by avoiding chronotropic side effects. So coming to the review, we are fortunate to have Will Wronowski in our panel today, who was one of the lead investigators of the PrimaCorp trial in 2002, which advocated the use of prophylactic high-dose milrinone to reduce the risk of LCOS. This study more or less paved the way for further research and use of inodilators in these such patients. A randomized clinical trial published by Momeni et al. In 2011 comparing levosimendan to milrinone in efficacy after corrective cardiac surgery. And they found that the rate pressure index, which is an indicator of myocardial oxygen demand, was significantly lower in the levosimendan group. Lechner et al. In 2012 conducted a study comparing the use of levosimendan again versus milrinone in pediatric cardiac surgery patients and concluded a post-operative cardiac index which was similar in patients who were administered both the drugs, although they did observe an increase in cardiac index over time in the levosimendan group. Evade et al. In 2012 compared the effectiveness of levosimendan and dobutamine introducing pulmonary artery pressures and cardiac index as indices. They found that while both significantly reduced pulmonary artery pressures and improved cardiac index, the mean cardiac index was significantly higher for patients receiving levosimendan. A systematic review literature published by Rowell in 2017 described the international practice variation in the use of inotropes. It reported usage of levosimendan in only 5% of the respondents compared to 97% for milrinone. And furthermore, only 1% of the respondents used it as a first-line drug compared to 42% for milrinone. Very noteworthy, it also pointed out that all the combination of inotropes do work to combat LCOS, but none had proven mortality benefit above the other. Dr. Kaushik and Dr. Balakrishnan in 2021 published a study comparing the use of levosimendan versus milrinone as a primary inotrope following pediatric cardiac surgery. They reported lesser incidence of LCOS in patients treated with levosimendan compared with milrinone. However, cardiac index and stroke volume index were comparable between the two groups. So coming to the present study, in this study, the authors have assessed the use of levosimendan as a first-line inotrope in congenital heart surgery. It was a prospective observational analysis done at a single center over a period of 1 year. During that year, there were 243 procedures performed, out of which 110 patients were included in the study. The exclusion criteria in this study being preoperative conventional inotropes, non-requirement of inotropes, patients undergoing closed heart surgery, and patients demonstrating low systemic vascular resistance on pump. So as for the protocol, In this study, patients received a loading dose of 12 mics per kg of levosimendan during rewarming on pump inside the OT, followed by a continuous infusion of 0.1 mics per kg per minute for 48 hours. The primary data set points which are recorded were heart rate, blood pressure, central venous oxygen saturation, and serum lactates. Secondary data set points to be recorded were mortality, duration of ventilation, length of ICU, and hospital stay. Cardiac output was not directly assessed, and LCOS was defined clinically as mean invasive arterial BP less than 5th centile after achieving adequate preload, along with any two of the following: arterial lactates more than 3 millimoles per liter on 2 consecutive readings, SVO2 of less than 50% or a decreasing trend, urine output less than 1 ml per kg per hour for 2 hours, and a heart rate of more than 90th centile. Now, as most common repairs that were included were VSD closures and TOF repairs, followed by switch and other biventricular repairs. Quite noteworthy was the fact that the authors had included complex cases as Al-Kappa, Norwood, and SV repair, in which LV dysfunction and LCOS is quite common due to prolonged aortic cross clamp times. Demographics were as follows: 62% of the participants were males and rest were females. The median age was about 346 and the median weight around 6 kgs. The patients were stratified according to complexity, and as expected, no RACS category 1 patient required inotropes and hence were excluded from the study. And the predominant group to be included was RACS category 2. Also to note, a significant portion of around 44% cases were RACS category 3 and above. So based on the baseline level of inotropes at the time of admission in the ICU, were divided into 3 groups. Group A received only levosimendan and comprised of 33% of the patients. Group B required addition of low-dose adrenaline and comprised of 54%. And the rest of the patients required further escalation to a higher dose of adrenaline or addition of a third agent. Over the course of ICU stay, only one patient in Group A required addition of low-dose adrenaline to further control LCOS, and 6 patients in Group B required further escalation or addition of inotropes. In this study, levosimendan was not assigned a score. Although LVIS score has been published by Favia et al. In 2013, it has still not been validated as a scoring system. Therefore, in our study, we calculated the inotropic scores using doses of other inotropic agents, which were added to a fixed dose of levosimendan, which was given a score of 0. In clinical safety, the authors witnessed isolated hypotension in 13 patients, which responded to volume administration, and at no point they required discontinuation of levosimendan. Tachyarrhythmia was observed in 3 patients. 2 had SVT, both of whom were part of Group B, and 1 patient of Group C had junctional ectopic tachycardia. Out of these patients, 2 patients were successfully reverted by the use of amiodarone, and 1 reverted spontaneously. Assessment of surrogate markers of adequate tissue perfusion indicated consistent decline of serum lactates, with 58% of the patients reaching a values of less than 2 millimoles per liter by 6 hours, and the increment of average SVO2 values over the 48-hour period. This improvement in tissue perfusion was independent of effect on heart rate over the study period, as depicted in this box and whisker plot, thereby not increasing myocardial oxygen demand. In this unit, the authors pursue a regimen on on-table extubation. They believe a successful on-table extubation is a surrogate for a hemodynamically stable patient on all fronts, including cardiac output. In this study, 49% of the patients were extubated and none required reintubation. None of the patients in Group C were extubated as they were deemed unfit, and as expected, the median time for ventilation was maximum for Group C at 66 hours. On an average, the patient stayed in the ICU for about 5 days and in the hospital for about 9 days. Coming to mortality, all patients in Group A survived. The overall mortality included 5 patients, out of which 2 patients had LCOS-related renal failure, both from Group C, and 3 patients had multi-drug resistant gram-negative bacterial sepsis. 1 was from Group B and 2 from Group C. The authors concluded that levosimendan could be used in all age groups in the entire spectrum of complexity of procedures with minimal side effects. It controlled LCOS alone in most children undergoing simpler surgeries without any positive chronotropic side effects, with an LCOS-related mortality of less than 5%. The limitation of the study being that there were no controls used for comparison and no direct assessment of cardiac output was done. The inotropic score did not take levosimendan into consideration due to no validated scoring system being present at this time. Furthermore, it was a single center pilot study undertaken at our institute. Further evaluation is needed to study the incidence of tachyarrhythmia due to this drug, and the authors have strongly urged for further studies to assess the use of levosimendan as a primary inotrope in congenital heart surgery. Coming to my takeaway from this paper, it definitely did demonstrate effectiveness of levosimendan to prevent LCOS in patients undergoing congenital heart surgery without chronotropic side effects, also including on-table extubation as a surrogate for stable hemodynamics. Cons, the author could improve on this paper by adding a control group to compare the levosimendan group and undertake further assessment on the incidence of tachyarrhythmias in further studies. And with this, I would like to thank you all for your patience. I welcome any questions that may arise.
Thank you, Dr. Avim. And thank you for highlighting important points of this paper, and we're open to discussions.
Perhaps I'll say something at the very beginning. And first of all, an excellent presentation of the paper. I think you have a great career in front of yourself as a cardiothoracic resident. Understand what the important issues are. So congratulations on that. I know it must be a little nerve-wracking at times, but you did a very nice job. Thank you for doing that.
Thank you.
This is no criticism of the manuscript by any means, but as a comment that I just was texting with John Costello about this, is that it's a challenge for us to determine what to use as a clinical endpoint for all of these studies. The authors did the best given the limitations we have with accurately measuring or reliably measuring systemic cardiac index and all the various things that go into that. And one of the things that I've been doing when I review papers and also when I talk with our staff is when we use the word required. In other words, we say a patient required 0.1 of epinephrine. We don't know if they required it. We do know that they received it. And it's the same sort of thing from on-table extubation, right? On-table extubation is a decision-making process made by the team. I think, as you said, it's absolutely correct as a surrogate for hemodynamics, but for stable hemodynamics, both of those are as much a reflection of human behavior and institutional processes as they are of the effectiveness of the treatment. And I am sad that we don't have this drug in the United States, at least easily, because all the good materials coming out of centers such as yours, Rhea, and I think it's great to see these papers. But I think as we move forward, trying to get, first of all, if you're all writing manuscripts, please use the word received instead of required, because I'll send it right back, and so will so many other editors. The other part is we need to find a combination of objective clinical parameters. Fortunately, in your manuscript, all of the measurable physiologic parameters were internally consistent. So the heart rate parameters, the lactate parameters, all of that were directionally consistent with the like what I call the human behavior factors of how to adjust the inotropes and what to do with mechanical ventilation. So I think there are absolutely excellent conclusions, Rena, from you and the team in what you presented, and it's a good stimulus for further trials. I thought maybe I'd call on John Costello, as you've struggled with this, as we did the Primacorp study together. We looked at some of the preliminary information, and you've done a randomized blinded trial with nasiratide. Maybe I'll open up the panel discussion to you, please.
Sure. I mean, Gil, thanks for including me, and Rena, congratulations to you and your team for publishing this very interesting paper. I mean, I'll just expand first, I think, on the comments Gil made about, the use of the word required. And in some of those situations, it's possible that another doctor may have come along, or another surgeon or nurse, and said, well, maybe instead of adding a second inotrope, I'll give this, back off on the sedation, or give this patient some volume, give a bolus dose of calcium. If there's some extra blood left over from the operating room, do that to augment the blood pressure and potentially cardiac output. So you can see how, as Gil alluded to, requiring a certain drug can be a little bit tricky in terms of an endpoint. But, I thought the other thing that I thought about when I was reading this paper is, the half-life of I want to ask you thoughts about the half-life of this drug, and particularly the metabolites, which are quite long. And it occurred to me that, potentially if the medication's administered, say, for 48 hours, and, but the half-life is several days later, that could be at a time point when the patient has certainly already been transferred out of intensive care and maybe potentially almost ready for discharge home, and could still be seeing some effect of that drug. So I'm curious for the folks, and I'm like Gil here in the United States, we don't have access to this medication. So I don't have personal experience with it, but I'm curious if people have thought about that and worried about the fact that the hemodynamic potential benefits of the drug may be wearing off when the patient's out of the ICU, or potentially ready to be discharged home even.
Thank you, Dr. Costello, for highlighting this lacuna in my paper. First of all, yes, I agree that we should have used the word received rather than required. I agree to it. And the next lacuna, which I myself feel in my paper, was that we did have all the indirect measurements of cardiac output in our paper, and we did not have any direct measurement like cardiac output from like cardiac index and cardiac output, which are echocardiographic based. Now, other thing which you have pointed out is whatever the patients who do not require inotropes after 48 hours, that's true. Now, what are we doing? That if the child is not requiring inotropes at all, first of all, we don't start, we take a judgment in the OR itself. If the child is not requiring any inotropes, like a Glenn would not require any inotrope, if there is no valvular regurg and this is not hurting the patient. Secondly, a Fontan would not require any inotrope, and a simple surgeries like ASD, VSD, and a simple tetralogies would not require any inotrope. And the patients who would be shifting the patients to out of the recovery in like 24 hours, we switch levosimendan in 24 hours now. We don't keep it for 48 hours. This is what we have learned in the past 11 years.
And that's interesting. And you touched on the answer to what my subsequent question. I was curious what the practice was at your center before you started developing this experience with levosimendan, and then now that you've completed this study, and I think you touched on this, it sounds like you're still using the drug, but I was curious what the practice was before the levosimendan was introduced into the armamentarium.
We were using a lot of milrinone in the OR, milrinone and an adrenaline combination. But as soon as this molecule was launched, I was really curious to use it. And it's not that I do not like milrinone or something like that. I cannot speak in front of Dr. Vinosky also. It's a wonderful drug to use. But we had our own issues, like, I don't know, it can be very subjective thing. What we found out that with the usage of with the usage of milrinone, we were using a lot of volume in the ICU, and it was causing a lot of vasodilatation in the ICU itself. And I think what I attribute this vasodilatation or the volume requirement for these patients, that we were extracting a lot of volume in the OR after modified ultrafiltration, and the patients were intravascularly depleted. So when I started milrinone in the ICU, I sort of asked my ICU fellows and the nurses, and I came to know that they are using a lot of volume in the ICU plus a lot of usage of vasopressors. So when we started using this levosimendan in 2011, I sort of did not find this thing that they're using a lot of volume and vasopressors touch in the ICU. And I think it causes a lot of afterload reduction, milrinone. Yeah.
That's interesting. And I see a couple hands up. Santiago, do you want to, not sure whose was up first, but you want to jump in?
Okay, thank you. So, thanks so much. First of all, to give my congratulations for Josie and all the group. They really good research, and also the paper is amazing at the way they have been writing. So, congratulations for everyone, and also for all the speakers. But I want to give you maybe different point of view that you are giving to us, because I have, as I told you, I'm in a hemodynamic monitoring group of 2 scientific societies. So maybe your approach is more into clinic outcomes. They're really important, but maybe I'm into more hemodynamic monitoring outcomes. So in that way, if you give me your validity per option, I want to share one moment my screen. I think it's possible. 1 second, please. And only I want to show something. It's like, are you seeing my screen? Is possible? Okay. So it's very fast. When we're speaking about the effect of levosimendan, is like at the first time, this is a short time of the sarcomere due to the contraction. What does it mean? Does it mean that the at least systolic time is shorter than before? It's like the heart rate is the same. For example, if you had a patient, this is also in pediatric and also in non-pediatric patients. So if you have a patient that is 60 heart rate, he has 1 second heart rate, okay? But what is doing levosimendan? It's like in this second heart rate, is shorter the time that the cycle gives times to systole. So we have more time for diastole. But what does it mean? It's like if the volume that I eject in less time, it becomes in more pressure. So this make effect of this inotropic drug is not going to eject more volume, is to eject the volume with more pressure. Sometimes we will eject the more volume, sometimes we will not eject more volume. But every time the volume that we will eject, we will be eject with more pressure. This is the point of view for me about the monitoring. And also because when we are speaking about how to monitor the drug effect, we should go to this part of the hemodynamic basis. Hemodynamic is basis in 3 points: is volume, pressure, and time. All the parameters that we work in hemodynamic are in the basis of this point. So as I told you, it's like maybe we don't eject more volume, but every time we will eject volume with more pressure, because if the systolic time is shorter, I should to eject the volume in more speed speed as like eject volume time. So this is very important. And in that sense, when we review all the works, and we speak about the responders and non-responders. For example, this study is like, oh, they say it's not responders because there are people where cardiac output is going better and people where its cardiac output is not going better. Why? Because cardiac output is or a stroke, for example. A stroke volume is a only volume variable of hemodynamic. And as I told you, maybe I can give levosimendan, but there are people that will eject more volume and there will be people that will not eject more volume about the basis of the problem in the myocardial structure disease. But everyone, all patients, it's very important, this second slide, every patient will be better about the parameters in hemodynamic that are studying relation between pressure and time, all the patients. So because in the past and also now in the moment, is like how we define it, that there are responders or no responders, about the how volume they will stroke or they will eject. So if it becomes better about the milliliters that he ejects in the stroke volume, we define that they are responders. And if it doesn't know this, we say that they are not responders. But this is not real like this, because if you study about DPDT, for example, hemodynamic parameters, all the patients go better. This is very important. And also, if you go to the biomarkers, NT-proBNP or lactate, everyone goes better. But the hemodynamic monitoring is very important also if in our studies, we introduce the hemodynamic parameters about how the drug really works. Because if we don't introduce the real parameters that value about hemodynamic drugs or inotropic drugs, maybe we will not have the real good results about we are looking for. It is only my opinion about the levosimendan. It's a great drug, but I think that maybe we are not studying as well as we should to study the levosimendan. Speaking about the hemodynamic monitoring, not about clinical outcomes. In that sense, all of you, I'm sure that you will know more than about me. Thank you so much.
That was very interesting, very granular data. The Kaushik, I see your hand up. Did you want to say something?
Okay.
Can you hear me, sir?
Now we can. Yes.
Yes, sir. Thank you for letting me in. There's just one point which I would like to make, which kind of reinforces what Dr. Santiago and Reena ma'am just made. That being that most of the studies which have been published to date rely on hemodynamic parameters for defining low cardiac output syndrome and hemodynamic coming out with better outcomes in terms of cardiac output with levosimendan.
Kaushik, you dropped a little bit, so I didn't catch all of your comments. I'm not sure if the other panelists did.
Yeah, am I audible now, sir?
Can hear you okay now.
Yes. Now, because we are relying a lot on hemodynamic parameters to define low cardiac output syndrome, and till date in the pediatric population, and because levosimendan has a better hemodynamic profile, I think as long as that is being used as a criterion for defining low cardiac output syndrome, most of the papers would have better outcomes with levosimendan.
But that's an assumption, right? Oh, he's gone. That's a shame.
Yeah, Kaushik, could you hear Pete's comment?
You're a bit difficult to hear, Kaushik, because you keep dropping out.
Yes, sir.
Unfortunately,
I think I'm losing my connection. Am I audible now?
Yeah, you're audible now, but then but I don't think you heard
Yes,
my question. My question was: you're assuming that children with the use of levosimendan will have a better outcome. We haven't seen evidence of that yet, have we?
Sir, there have been a lot of papers which have been published over the last decade or so in the pediatric population. That's the point I'm trying to make, because a lot of them rely on lactates or central venous oxygen saturation, as well as the blood pressures. So because levosimendan offers a better hemodynamic profile, maybe we're getting better outcomes with levosimendan compared to the study drug, compared to your standard inotropes.
But the papers that have been published all show like a similar results comparison to milrinone, and none to normal saline or to normal controls even. So I don't understand. Are you suggesting that if those papers had used different outcome parameters, then we would have shown a benefit of levosimendan?
Yeah, if we had used different parameters like direct measurements or say all-cause mortality, like how the adult population, there were recently published trials in the adult population regarding composite endpoints, like your all-cause mortality. Maybe then we would actually know if it is a better drug as compared to the other standard regimens that we use.
Yeah, I understand your point.
Can I answer you, Pete?
Yes, please.
So, hi, I'm a pediatric cardiac intensivist. So I used to work like 10 years ago in France with levosimendan when everybody else was thinking that levosimendan does not work. So we really believed in it. And then I worked in Lebanon and now I'm in Belgium. So for the studies you're talking about levosimendan not being significantly better than other inotropes, there's something you have to notice. First of all, it's the dose of the levosimendan. So the studies that showed that levosimendan is as equal to milrinone or does not work are the studies that used a lower dose of levosimendan, which is 0.1 microgram per kilo per minute over 24 hours. But the effective dose should be 0.2 micra per kilo per minute over 24 hours or 0.1 over 48 hours. So it's the cumulative dose that should be 0.2. So this is very important. And this has been criticized in a lot of reviews and systematic reviews as well. So this is the first point. And the second point is that the timing of initiation of levosimendan is also critical. In the paper we've seen, the levosimendan was started in the OR, which is very good and which is why it works. Because when you start it later on as a rescue therapy, it's like ECMO, sometimes it doesn't work. So it's really about the timely initiation of levosimendan that should be early enough. The studies that have shown significant results, whether in hemodynamics status or duration of mechanical ventilation, mortality, weaning from ECMO, are those that use it really close. And these are patients with congenital heart disease, but also adults with congenital heart disease suffering from pulmonary hypertension and right ventricular failure. So patient selection is important, of course, but early initiation and mainly the dose of levosimendan that should be used. And there is a big data from France that is coming along and should be published soon. So thank you.
And do you think that some of the studies have used a loading dose and others have not? Do you have thoughts about that issue?
Yes, so loading dose, this is my personal experience. Loading dose in the pediatric population when it's done over a pump, so on by the end of the bypass, is well tolerated. However, when you do it as a bolus in the pediatric or in the adult population, sometimes hemodynamically it's not well tolerated and hypotension might occur. So the studies that have shown that levosimendan works, these are people that did not use a bolus of levosimendan. They only use the total or the cumulative dose that works, so without a bolus. So this is my personal experience and the papers we've seen.
I have a comment here to make, Dr. Costello. So we were trying to compare milrinone or levosimendan to any other inotrope. And this is my view that no inotrope is an ideal inotrope. We all believe this fact. No inotrope is an ideal inotrope, first of all. Second thing is that it's not like one size fits all. So if milrinone is suitable in this condition, levosimendan may be suitable in other conditions. So I think it depends on the pathophysiology of the patient, the age of the patient, the condition of the patient, the time of bypass, what sort of cardioplegia we have used, what sort of disease we are dealing with. Suppose we are dealing with a very cyanotic congenital heart disease, and we're looking at very low SVR on a bypass on CPB. So I usually will not start any chronotropic, any inotropic agent there. I usually get away with a vasopressor in that situation. Day before yesterday, we did a unifocalization and a complete repair for a single stage repair for a pulmonary atresia VSD. And I did not use any inotrope there. I used a very small dose of vasopressin because the clamp time for VSD closure was only 27 minutes. So I really do not believe that either milrinone or levosimendan is a holy grail and it will work for everyone. I think we need to choose our own drug, and definitely depends on the institution protocol also. That's what I believe.
Yeah, that's very thoughtful. And I did notice when I was reading your paper that I think there were only 2 single ventricle patients in there. So the majority of the 110 patients were biventricular repairs. So that your comment, fits with your practice in that regard. I see a couple other hands up on the panel. I'm not sure who was next, but Dr. Iyer Pavarthi.
Yeah, hi, hello to all of you. Reena, that was very enjoyable. Yeah, good to see you again. Basically, what I wanted to share with you is that over the years, we've sort of moved away from minimizing our inotrope utilization. I mean, so most patients really need to earn an inotrope. And our experience with levosimendan has been very selective, and it's mostly for late presenting congenital heart disease, largely the late presenting arterial switches. transposition intact septum, in whom we've done a late arterial switch, and who have significant profound low cardiac output, as well as those with severe pulmonary hypertension, where you have both biventricular dysfunction and pulmonary hypertension, where we've used levosimendan not only for myocardial support, but also as a pulmonary vasodilator. And the third group has been the very, very sick Al-Kappa, and occasionally for weaning from mechanical support. And our indication has been largely to use levosimendan in these scenarios, and our experience has been very gratifying for rescue. We had 2 instances of tetralogy of Fallot who almost went on to ECMO for bizarre rhythms, and while getting the ECMO circuit ready, we decided to try levosimendan. I know these are just anecdotes, but it worked, and the baby went home in 5 days and completely neurologically intact. So what I'm saying is that levosimendan, I think, has a lot to commend itself, but our tendency and our practice has been what Dr. Gilvanowski says, that we all know what the nadir of the low output is, that we try and let most of our patients earn hemodynamic support rather than commence everybody electively in the operating room. And one of the other points that I wish to add is it's very difficult to compare in terms of mortality, because most of us now have a surgical mortality as well as a discharge mortality, and the 30-day mortality, close to 1 to 2%. So you need phenomenal numbers to say whether levosimendan has improved mortality or not. So all we could do, frankly, is to have very gratifying anecdotal experiences like this. But these are in very, very select group of patients. The other point that I'd like to add is with levosimendan in India, I don't know what the scenario there is. The market availability has been very, very random and very erratic. And currently at the moment, again, it's not available except in the black market in India.
Good evening, ma'am. The question regarding the availability of levosimendan, we just got it back after 3 months, and Samad Pharmaceuticals is providing us this medication again.
Yeah, well, they have just said to us that they don't have it.
And Dr. Costello, thank you, ma'am. Dr. Costello had asked me this question, that what anatropes was I using before using levosimendan? And I would like to share that I still use milrinone along with levosimendan, and I've not written about it. I still use milrinone along with levosimendan in the scenarios where I need extreme afterload reduction, like in late switches, 1. Second subset is my Al-Kappas. And third is single ventricle Norwoods, where you really have to work on SVRs. I use a combination of levosimendan and milrinone there.
Yeah, that makes sense. Do others have experience using both drugs together?
No, we
yes,
usually
John,
turn off the milrinone.
Yeah. We've used milrinone and levosimendan in very late presenting shunts with severe pulmonary hypertension and biventricular dysfunction, but I just have a handful of patients in that group, and they all did well and they did go home.
Because what I remember from my clinical fellowship days is that when we were using Norwoods and all, when we were doing Norwoods and all, we used a lot of phenoxybenzamine in the OR and the phenoxybenzamine drip in the ICU as well. But I don't think so we are using phenoxybenzamine anymore. We have such wonderful vasodilators in hand. So I think I've stopped using phenoxybenzamine now. So instead of that, I've started using a combination of levosimendan and milrinone.
Interesting. Jai, you've got your hand up.
Yes. Yeah. Hi. Good morning and good evening to most of you. I know we are around the clock in the world here now. I joined late. I'm so sorry, my link wasn't working. I'm at West Virginia now. Been at Sidra in Qatar. And again, hi Jenna, hi John, hi Sasha, and I think I know Parvati from PCICS and International Committee. So good morning to and good evening to all of you. I think a few things. It's really, as people have said, we don't have this drug in the US, so we don't use it here except the compassionate use, which also is very hard. I've used few patients in Sidra, Qatar, and Middle East in Sidra Hospital. But focusing on the paper, really a nice pilot study, I'll call it, as you probably have referred yourself, Dr. Joshi. I must say that when we are trying to introduce, maybe that's the reason it's not getting popular in the US, and people, that 15 clinical trials going on, I was noticing in the world in children, and none of that is in the US. Maybe I'm wrong, maybe something's happening, I'm not aware, but at least registered trials I was looking at. So point I was trying to make is that when you have one standard of care, which we all use now, and thanks to the previous work from many of you and many of other great contributors. So milrinone being the standard, 0.3, 0.5, you come from the OR, some people load, some don't. Then something like this comes into the plate. We all have to be skeptical as we are and try to compare what we're already using it. So my one, not that's a big criticism, but I just want to say that it would be nice to see that comparison. I know you have majority of patients on a 0.1 epinephrine also coming out of the OR. So that's not a low cardiac output syndrome coming out of the OR. It means that the kids did not do well at all. Looks like regardless that you required epinephrine of 0.1. Now I know that epinephrine 0.1 is a small dose for many of the people in the world, but we here consider 0.1 a high dose epinephrine. To be honest, when I'm crossing 0.1, I'm thinking about ECMO, and I'm thinking about some other things that patients not doing so well. I know some of our European colleagues and Asian and Middle East, we use a little high epinephrine. So my question would be that the limitation-wise, would it be possible that we have a head-to-head comparison with milrinone and then try to see the low cardiac output syndrome later on? Because I personally would think in a humble way that the conclusion of the study, again, needs to be rephrased in such a way that we did not show effectively the low cardiac output syndrome is better, if we focus on this paper particularly.
Thank you, Dr. Jay. I would like to answer both the questions of yours. First thing is that I accept that we did not have any control group in my paper. I accept it, but it was a pilot study, as I've already written about it. Secondly, you said that adrenaline in the dose of 0.1 mics per kilo per minute is a higher dose, and I believe it. That is why patients who were kept in group C had higher RAC score also. They were the patients who had RAC score of 3 and 4. And I personally feel that more than 0.1 mics per kilo per minute of adrenaline is a bigger dose. That I agree with you. Second point, you said that if the patient had adrenaline of more than 0.1, I would put those patients on ECMO. Well, I don't agree to this point, because putting a patient on ECMO, I think an inotropic score of more than 15 or 20 is considered worldwide, I think so. And 0.1 mics of adrenaline is only inotropic score of 10. And
I didn't mean to, I said we start thinking about, it's just that you worry about the patient a lot. Of course not, we don't, of course, jump on ECMO right away, there's own problems. So, so I just want to
agree. Yeah, Dr. J, I agree. Like if I'm using a combination of 0.1 mics of adrenaline, 0.1 mics of noradrenaline, lots of calcium and lots of vasopressor, I would definitely consider putting this patient on ECMO. Thank you.
Just thinking about Jai's comment, I'm curious if the other panelists who have experience using levosimendan would feel like there's equipoise for a randomized trial, or you believe in it so much at this point. And of course the other issue, and Parvati touched on this as well, and as of others, are just the nuances of picking the right patients. I mean, these postoperative patients don't have all the same physiology. Some are vasodilated coming out, some really need aggressive afterload reduction, and so on. But that being said, if you looked at say, neonates undergoing complex biventricular repairs, like a VSD interrupted arch, a neonatal TET repair, an straightforward arterial switch operation. Will people, for cases like that are at risk for having low cardiac output syndrome, do people feel like there's equipoise to randomize those patients, or do you think that horse has left the barn? Do you think that wouldn't be feasible?
John, we will need a huge multi-centric study to get any kind of numbers, because in most cases for a normal arterial switch, I mean, one hardly needs any inotropes, you know. The ones who really need anything are the ones who present late in the natural history. So, you know, I mean, you need to collect, like over all these years, we've just crossed over 100 late arterial switches. So, you know, what I'm trying to say is, and this is over a 25-year span. So if you really want to compare, you know, we can't compare apples with oranges, but if you really need to get a particular kind of subgroup whom we feel that levosimendan will actually alter things, I think you do need comparable groups and you need large enough numbers. And for that, it will have to be multicentric. I mean, we are a very busy program, but even in our scenario, with the tendency to, you know, focus on good, swift surgery, you don't really need a lot of hemodynamic support. So if you do need hemodynamic support, and it's in this very sick group, so you need, you know, large numbers of sick people to compare. And for that, you need, I think, a multicentric study so that you can get equivalent numbers and statistically viable numbers, you know.
Sure, you would have to have a carefully thought out endpoint. Pete, you've got your hand up?
Yes, I just wanted to throw a little curveball out there at the end of the hour, because like our speaker said so well, levosimendan is a new kid on the block, and it has to prove itself amongst the other inotropes that we use. Yeah. And somebody just said that milrinone is the golden standard. Gil has unfortunately left, but John is still there, and I'm here to say, but I still dare to make this next comment, that I think that milrinone has not proven itself either. But we want levosimendan to prove itself towards milrinone, but maybe we should also compare it to normal controls without any drugs, or an aceratide, or thyroid hormones. You know, there are so many drugs out there, and I think, as has been mentioned before, you will have to have certain drugs for certain children with certain diseases and certain points of time in their disease process, and no drug fits all, absolutely not. But it's very hard for levosimendan to prove itself, and just like Pravati said, we would need so many patients, and preferably patients with the same diagnosis and the same operation, and that's going to be very, very difficult.
So, Pete, can I ask a question in that regard? A quick question. So, any complex surgery or any surgery coming out of the OR after bypass, do you guys use a standard regardless of the hemodynamics? Maybe coming on milrinone?
Yeah, unfortunately, we do. Because I'm not alone. Maybe I'm wrong.
Every day, why is that?
No, I could very well be wrong. But I do want to think about this. But what I do think is wrong is that every child gets the same drug dose of milrinone, because I think we don't need to all give them milrinone. I think it might even be harmful if we, like somebody said, I think before, we give too much volume, and we overload them. And but I want to know which patients. I want to prove it with research, and that's very difficult, because there's a lot of hypotheses going on at the moment, in my mind, in your mind, and the truth is somewhere in the middle. There's so much to learn, I think, for something we use so routinely. I find it very difficult.
You know, milrinone has been in use a lot, and I'm aware that many people electively utilize it in the operating room, but there have been, not anecdotal, but several series of reports of fairly nasty tachyarrhythmias with milrinone. And what we learned over the years is if you don't need any hemodynamic support, don't give anything. And, despite very complex surgery, just focusing, on simple things, we've managed to really cut down our hemodynamic support utilization. So effectively, we really need hemodynamic support. We only use hemodynamic support if you need it. And these are the patients who, in our scenario in India and in our unit particularly, because we are known for late presenting congenital heart disease, we really utilize hemodynamic support only for late presenting heart disease. And if some parameters are there to suggest borderline low cardiac output state, otherwise we really use almost nothing.
Santiago, you've had your hand up for a few minutes. Do you have a quick comment? We're up against the hour.
Okay, yes. Only I want to take from you 2 minutes and anything more. It's like about the reasons to use milrinone or, for example, levosimendan. As I told you before, I'm work more in the basis about the pharma. So first of all, I don't know if you know, but the molecular of levosimendan was born doing the mix between milrinone and introprusiato. I don't know if you know that. So if you want to compare inotropic with levosimendan, the inotropic more similar to levosimendan is milrinone, because the basis of the chemical molecular is more or less the same. Like it's together to introprusiato. And in fact, if you go to where that the molecules make the effect, milrinone and levosimendan are in more or less the same area. It's not like the butamine. If you put together the butamine with levosimendan, for example, you can see more synergic effects. But if you work with milrinone and levosimendan, synergic effects are not easy to find. It's a molecular effect, is a pharmacodynamic reason. And also, when was the doctor speaking about where is the moment to use levosimendan and the dose, more important is like we should to know that the effect of levosimendan is from the active metabolites. These active metabolites start to be high rise in the blood concentration like 24 hours before you start to use levosimendan. Because at the beginning, you will find the effect of that, of introprusiato. It's in the part of the molecular of levosimendan, as I showed you. So it's important because many times we use the pharmas, we are speaking about the clinical outcomes. But if we know before of all the chemical and the pharmacodynamic effects, maybe it's easy to find about how it's going on. And more important about the moment to use levosimendan is like, if I want to effect on levosimendan now, I should have started 20 hours before. Because if I started now, I will find the effect of vasodilator effect, okay, for introprusiato. But the effect of levosimendan should not to be studied at the beginning about pressure. It's like perfusion, because many times there are patients that are blood pressure goes down, but the index of perfusion going up. So it's more important to do a correct hemodynamic monitoring, and also don't speak only about the mortality, because as the doctor told before, mortality is very difficult to speak in this kind of person, because there are many factors that can disturb the results of the research. And that's all. Thank you so much, and congratulations for the speakers. I'm very happy to stay here with you.
Yeah, Santiago, that last slide emphasized the point I was making earlier, because the x-axis there was days, and it looks like, the drug is hanging around, and the metabolites are hanging around for longer than some of these patients may be in the ICU or even in the hospital. So very interesting. Well, I think we're running over our time here, and so we should probably wrap up. I just wanted to congratulate Dr. Ratan for that outstanding summary, and to Dr. Joshi and her team for putting together that series and agreeing to lead the discussion in the Journal Club today. And Gil had to jump off to deal with a issue in the ICU, so I'll wrap things up here if that's okay. And just like to thank all the panelists for participating, and there were many participants. I saw over 130 participants involved at one point. So I thought this was a great session personally, and especially, and Jai may agree, but being here in the US where we don't have access to this drug, I anticipated learning a lot during this Journal Club today, and certainly did that. It's very thought-provoking as well. It sounds like we've got a lot of more work to do in our field about inotropic support in our postoperative patients and some other subsets of patients as well. So this was really great. Thanks to everybody. Great to see a number of familiar faces this morning. Have a great day or a great evening, depending on what part of the world you're in. And we'll see you next time. Take care.
Thank you so much.
Bye.
Thank you so much, everyone. Thank you so much. See you.
Thank you.
Thanks a lot, everybody. We'll see you soon. Bye-bye.